So we welcome our next presenter, Dr. Prashant Srivastava, sir.
Good morning, everybody. So I'm presenting a very basic topic about the complication of glaucoma surgery, and I will be sharing few situations where it was managed. So we know we have to understand the complication are part of surgery, and TRAB it is even more than a normal cataract surgery. So complication could be early post-operative or intraoperative. To prevent complication, we have to understand at what step a complication can happen. So while dealing the conjunctiva, we have, if you're using a tooth forceps, then it can happen. So use non-tooth forceps. That is how we prevent it. Scleral flap damage, I will tell in details. And like for bleeding, for intra bleeding, we have to go for gradual decompression of the, and also stop all the anticoagulant before the surgery. Now, if the scleral flap damage has happened, what we do is we first try to see whether the sclera has damaged. If the scleral flap damage has happened, then we first see whether we have created a stoma or not. If we have not created a stoma, we can choose another site. If you have created a stoma, then we have to close the site with the patch graft. So this is a video where the scleral flap damage has happened while making the flap with the crescent knife. So in the superficial layer, so there was a tear in the sclera, this here. So since it was very small, it was managed conservatively, just went deeper and choose a little deeper plane, and then the stoma was created. And after that, it was with the Kelly's punch, and then just a nylon suture on the top of the scleral flap could save the surgery. If it was large, then we have to close this with a patch graft and choose another site. If we had not created a stoma, then probably we had shifted to some other place. This is how a scleral flap damage is managed. Now this video is given by Dr. Maneesh. It's a case of congenital glaucoma where there's congenital in the TRAB case where premature entry has happened. So you see the sclera is very thin, and while making the flap, the bed of the stoma was damaged and the aqueous started leaking. So it was also managed conservatively, just we went superficial to the flap, superficial to the area of damage, and then it was sutured conservatively. The patient also did well. So small damage can be managed conservatively. So I had a few complications, but I cannot show this because of interest of time. In post-op, we have bleb leak. So this is a video where you can see while doing the schedule, we can see the bleb leak over there. So generally, if you have a bleb leak, first thing we do, we patch the eye. If some people give Diamox for better healing, or we patch the eye, call the patient next day, again observe whether the leak is present or not. If the leak is consistent, we put a BCL, probably a large size BCL of 16 millimeter, and then we follow with the antibiotic cover. And the BCL can be kept for a month also, and in this way the baby generally heals. If it doesn't heal, then we have to use sutures, like Debasis was telling. We can suture the leaking bleb, and generally these patients do well. It's a very common complication in the case of TRAB. And this case was a case of primary opening glaucoma, was doing well initially. First post-op day pressure was normal. When we came at 7th post-op day, pressure was high. But what I did was I removed the reusable suture, and then when the patient went into hypertony with shallow AC. So this is how it looked when the reusable suture was removed. The chamber became very shallow. The bleb was large and diffuse. And IOP was less. So generally what we do, we can use a pressure bandage, we can give a cycloplegic. So this is how the slit lamp video looked like. It was very shallow, was not touching, but was almost touching very close to the cornea. There was no choroidal. So this, we give a strong cycloplegic and then observe the patient. So this is a case of over-filtering bleb. So I was very aggressive removing the suture early. So generally we should not remove the reusable early. If there's little IOP spike in immediate post-op, we should just give a gentle massage. The bleb will form. If you remove the bleb suture, then there is no chance you can suture it again unless you go to OT and suture it. So this case was managed conservatively. If it's not managed, then you have to take the patient in OR and push the suture again. So these two cases. Other cases I am not discussing in lack of interest, lack of time. So over-filtering, we generally give cycloplegic, and then we have to suture it again. Thank you. Thank you, Partha, sir, for giving me the opportunity to share the cases.
Sir,
case-
according to you, which type of leak is actually more dangerous, early leaks or late leaks?
Early leaks are easier to manage. Late leaks are difficult because generally it happens because of the mitomycin or any adjuvant. Early leaks, because the vascularity is good, you can, even with the patch graft, they heal so well. You give something at the adjunctive. And then with BCL and all, early leaks are easy too because the vascularity, it heals fast. Late leak happens because of maybe conjunctival retraction or maybe overuse of mitomycin. So those are difficult ones. May need a conjunctival autograft also.
When to remove the suture?
Releasable one.
Releasable suture. When to remove, when not to remove.
So first, so if you put a two releasable suture, you can remove it in first week also if the IOP is high. So maximum last would be 3 weeks. After that, it doesn't.
3 weeks, okay. And earliest?
Earliest 7 days, not before that. In this case, it was removed, I think, 2 days after that, and it led to a overfiltering bleb.
2 days?
After 2 days only. It was initial videos. When I was like, I thought the bleb is flaming, so I just.
So ideally, when you remove suture?
7-8 days. The first suture I removed 7-8 days, sir.
Oh, you put 2 sutures?
I put suture.
Okay.
Two sides.
Okay.
So what is your, sir?
If there is overfiltration,
Yes, sir.
you try first conservative technique.
First we try
How
conservative.
long do you wait till you
If there is no cornea iris touch and no choroidals, and so there is no threat, so we can observe it. Vision is not. So if there is no touch, then only we can observe. If touch has happened, then we have to intervene. We can just take the patient in the OT. Primarily, we can just inject viscoelastic or air bubble to form the AC.
Sir, usually these cases, they get subsidized without much problem actually. Just put the cycloplegic, and if there is no choroidals, nothing to worry about that. We wait at least 2 weeks to get settled down. If doesn't settle down, for me, I just put the air in the OPD itself. It looks very irrational, you can say, but just put the air in the OPD itself with a 30 gauge needle. And 2 cases, it just got AC was formed and everything settled down.
So you take 1 ml syringe and just inject from
with the tuberculin syringe, 30 gauge needle, just make small entry in the slit lamp and just inject the air. AC forms and just it slowly settles down. 2 cases I did. Probably in the last more than 20, 25, 22, 23 years like in that thing. And both of them settled down. Yes, one case I have to put because it was overfiltering. It was, I realized it is not, the air is not going to help. I took to the OT, then put the viscoelastic. After putting the viscoelastic, it nicely ballooned. So then table had realized, yes, it is not the case where you have the viscoelastic only can help you. So then I have to open and put the suture. So that was one case what I did, but most of the cases what you said, most of the cases it settles down without much problem. But 7 days, before 7 days, we should not remove the suture. After 2 weeks, probably the suture help doesn't help us too much. Yes. And theoretically you can say 3 weeks, but 2 weeks is the time when if you have to remove it in 2 weeks, otherwise it's not going to help. Yeah, that's what, 2 weeks, that's what, roughly.
So how do you decide when just putting a viscoelastic will do the job, or you have to open the...
See, basically when putting the viscoelastic, when you put the viscoelastic, wait for some time. If it's a sclera is open, it just ballooned up.
Yeah, ballooned up, yes.
So if superior sclera is ballooned up after putting the viscoelastic, this means no. The flap has to be sutured.
Is there any choice of viscoelastic that you will use a coercive one or
no,
just
no.
SPMC?
See, basically, you are just dealing where you are not sure whether what kind of, how much you have opened up. So if it's ballooned, then there's no point putting the high molecular viscoelastic. If you are putting the viscoelastic and just, if it's ballooned, just open it and just suture it.
If it's not ballooning, then you can put a high density also.
Yes, no, usually it's not needed actually high density.
Normal one will do.
Normal one, it just takes care of that.
opening is always BTEC or transconjunctival suture?
Not really. If nicely, what happens? If you can see that scleral flap becomes like this. If it's a tenting like this, you have to open and suture it.
The problem is bleeding is again bleeding is a big problem.
It is a difficult. That's why I said you don't want to do that. But if it's opening like this, then tomorrow also it's going to be like that only. It is not going to heal.
Yes. Thank you so much, sir.
Thank you so much, sir.